Good morning, good afternoon, good evening, wherever you are. Welcome to Virtual Grand Rounds. Premier education brought to you at no cost thanks to our sponsors, AstraZeneca, Medtronic, and Medela, the Science of Care. This week, it's a delight for me to present Professor Enoch Akowuah from the Southeast Academic Cardiovascular Unit. You might be wondering why a heart surgeon is going to be presenting about Pectus, and the reason is because Enoch is doing one of the first, I believe, a randomized trial for Pectus surgery. So Enoch, over to you.
Brilliant. Thank you, Eric, for the introduction, and good morning, or as Eric says, good afternoon, good evening, wherever you are. So my name's Enoch Akowuah. As Eric says, I'm a cardiac surgeon, but I'm also an academic, and I'm really interested in designing and delivering clinical trials. And I'm the chief investigator of the Restore trial, along with Joel Dunning, who is my thoracic colleague. The trial is funded by the NIHR in the UK, so that's the National Health Service funding body, and it's being delivered by the Academic Cardiovascular Unit where I work. So the background and the rationale for the trial is set out in the slide. Pectus is a relatively rare disease. Um, it occurs in about 1 in 1,000 people. Um, Corrective surgery for cosmetic indications is well developed and is very commonly performed and valued by patients. However, whether surgery objectively improves your physical function and your cardiopulmonary function has actually never been assessed in a randomized controlled trial. So all the evidence on which the operation is based is retrospective data. And over the last few years or so, funders in particular, but also patients and clinicians have become increasingly skeptical of the value of this major operation to correct the physical limitations of Pectus beyond cosmesis. And those of you in the UK will be aware that in 2019, the National Health Service decommissioned Pectus surgery, which means that they stopped paying for it, on the basis of lack of high quality data which demonstrated an improvement in physical or cardiopulmonary function. And internationally, we know this is a problem because lots of HMOs and insurance companies who pay for care have similar concerns and have over time similarly restricted funding for this operation. So that's the clinical setting in which the question is based. So the trial has two main objectives. There's a health economic objective and a primary clinical objective. So we're going to set out to determine whether corrective surgery is superior to no surgery measured at 1 year in terms of your change in physical function. And the tool we're going to use to measure that is called the SF-36. Some of you might be familiar with it. I've got a slide telling you more about it later on. And we're also going to try and determine whether surgery is superior to no surgery in terms of improving your cardiopulmonary function. And we're going to use a cardiopulmonary exercise testing, which I'll call CPET going forward, to assess that also at 1 year. And because this trial was commissioned by the NHS, that the sort of health economic evaluation is also a key objective. So we're going to estimate the cost for every quality adjusted life year that is achieved with surgery. So those are the, if you like, two main objectives. Those are the primary objectives. They're two primary objectives. I can see the statisticians already rolling their eyes because trials only answer one question, but I'll tell you how we're going to answer those two questions with this trial. I'm not going to spend too much time in the nitty-gritty of the trial protocol. That's already published. It's in the BMJ, so you can just Google that and read that. It will give you the detail. But I will just highlight on the key kind of trial design features. So the first thing is the trial design. So it's an investigator-led, it's a pragmatic RCT. We're recruiting 200 patients. 100 will be randomized to the intervention, which will be surgery, and 100 patients will have no surgery. Patients will be followed up for 1 year, and the trial is taking place in 10 cardiothoracic centers, or I should say thoracic centers in England only. We began recruitment in August 2023, and recruitment has already closed in October 2025. And I'll also again make a point that we'll be following patients up long term. But again, I'll give you details of how we'll do that. But for the purposes of the rest of the talk, really, we're talking about the RCT where we're finding differences at 1 year between groups. This is the intervention. So the thoracic surgeons amongst you will recognize these two operations. There's the Ravitch procedure, which is, if you like, the traditional operation. Is an open operation for this condition. And then there's the NUSS, which is more minimally invasive, where bars are inserted into the thoracic cavity to elevate the sternum. And the number of bars vary depending on the severity of the pectus. I would make the point that these are major thoracic operations. The breach of thoracic cavity, you require drains. It's a lot of pain. There's a decent length of stay. So these are significant surgical interventions, and that's why I think the clinical question is so important. So how do you get into the trial? What's our target population? And essentially, you need three things to get into this trial. The first thing is that you have to have severe pectus excavatum. And we define that by having a Haller index of 3.25 or more. And for those of you who are not familiar with the Haller index, it's measured on a CT scan. So every patient has a CT scan, and it's a ratio of your width, of the width of your thoracic cavity to the depth of your thoracic cavity. So as the Haller index goes up, then your severity of pectus goes up. So if you like, if you have a perfectly cylindrical chest, your Haller index will be 1, and as you get more and more depression, the Haller index goes up. So 3.25 is an accepted threshold for severe Haller, and so that's your first criteria to get for severe pectus, and that's your first criteria to get into this trial. Then the second criteria you have to meet is that you have to have symptoms, and you have to have one of these symptoms. So you have to have shortness of breath or impairment of your exercise ability, syncope or pre-syncope with exercise, arrhythmias on your ECG, which are attributable to pectus, so there's no other reason to have the arrhythmia, and similarly dysphagia or swallowing abnormalities in the absence of any other cause. Okay, so once you've hit 1, and then you've hit 2, then there's the third and final criteria, which is that your SF36 physical function score has to be 80 or less. Okay, the score of 100 is the perfect score, but you have to score 80 or less. So when we approach patients for the trial, they all have a CT scan. We then take a history, and then we do the SF36. And if they meet all three criteria, then they can be considered to enter the trial. So I guess I highlight this because it's to make the point that this is an enriched population, and these are patients who are physically impaired and who need the operation not just for cosmetic value, but to improve their cardiopulmonary function. This is the SF36 test. We're just using the physical function score. For those of you who are familiar with SF36, it's a battery of tests that measures quality of life. There's a whole battery that measures mental function, as a whole battery that measures physical function. And within the physical function score, there are several domains. We're using the physical function domain. So it's 10 questions that you have to answer. It's really well validated. And we have a minimally important clinical difference. So it's a tool that we're familiar with and has been used in lots of trials. Our secondary outcome, our key secondary outcome is cardiopulmonary exercise testing. Again, some of you might say, oh, why didn't you use that as your primary outcome? The NIHR, and in my view, rightly focuses on outcomes, primary outcomes that are important to patients. And when we did our PPI work, patients were very clear that they didn't really want to know what the value of a number, your VO2 max or whatever is. What they really wanted to know is the answer to the question about how they feel and what they can do. So that's why the SF36 is our primary outcome, but we felt it was always important to kind of have a secondary outcome that would explain the findings of our primary outcome, and so we introduced CPET into the study. CPET in clinical trials is complex because availability of CPET in the UK is difficult. There are lots of different protocols, so we had to do a large Delphi consensus exercise to really have a CPET protocol that's uniform, which allows every patient in the trial to have the same test. And also because they're repeated tests, it meant the patients have to come back to the same center for repeated tests. So we thought very hard about how the CPET is performed. Some of the key features of the protocol are here. Again, this is a paper that's out in print at the moment and will be published. So you can read about the CPET protocol that we use in the Restore trial. And we hope that will be really the sort of if you like, the best practice template that will be adopted going forward. We have a number of secondary objectives as well. I won't dwell too much on these because they are what they are. They're secondary objectives. But we wanted some information on quality of life, as I've already said. We've got some disease-specific questionnaires that some of you will be familiar with, which we've asked patients to complete. We measured levels of depression and anxiety. We're obviously going to measure adverse events as an important operation. One of the things we did, which hasn't really been done before, is to measure technical success. So everyone who has an operation has a CT scan after surgery to make sure that the operation has worked well. And we've introduced this because, as I said at the beginning, Pectus had been decommissioned in the UK for about 4 or 5 years before we started the trial. And the issue of learning curves and the quality of the operation was really center in our mind at the design stage. And so we wanted to make sure that we could, if you like, defend the integrity of the trial. We didn't want to be criticized and say, "Oh, these surgeons haven't done the operation for a while, so maybe they didn't do it very well." But so we have got objective evidence of the quality of the operations done. And then we've got a couple of other things. We're in particular doing a discrete choice experiment, really to kind of understand why a patient might choose a Ravitch over a NUSS. But these are secondary questions, and we will report them separately from the primary analysis. How do we get to our 200 patients? This is our sample size calculations and considerations. So prior to the trial, we asked a number of patients who fulfilled our eligibility criteria to complete the SF-36, and that gave us a feel of the spread of the SF-36 score in this population. Based on that data, we calculated that we needed 170 patients to show a 90% power to show a difference of 15 points in the SF-36 score. We already know that the MCID is 10 points for this population. So we know that recruiting 200 patients with 15% attrition will give us 90% power to answer our primary question. So we know that we're set fair if we can recruit those 200 patients and keep them in the trial, which is obviously important. So that's the highlight of the trial design. As I say, lots of detail in the published paper, so please have a look. And I guess the next few slides are not out in the public domain, so here goes. How have we got on? We got on really well. I can quite confidently say that I'll never have this recruitment chart in any other trial that I do. We had planned to finish recruitment this summer, so July 2026. In fact, as you can see by the green line, recruitment was really brisk right from the outset of the study and continued to be brisk as we opened more and more centers. And so we're actually able to finish the trial nearly 10 months early. So amazing work by the thoracic surgical community. This is my first trial with thoracic surgeons, and they've outperformed the cardiac surgeons who I usually work with, and I use this slide all the time to beat the cardiac surgeons up with. So well done to the sites and to the patients and to the research teams out there who were able to deliver this trial early. This is so important because it means that the answer for the question will be provided much earlier than anticipated, which is great for patients, and it allows the NHS to make commissioning decisions a lot earlier. And also means that within our funding envelope, we can follow patients up for longer. So double good news, really. Yeah, again, congratulations to all the sites out there. So this is what's happened to the patients. The trial is ongoing, so this is our trial flow diagram. So we screened 334 patients. About 100 of them were ineligible because they didn't meet the entrance criteria. We consented 239 patients. And because we did the SF-36 as part of our baseline screening test, that normally happened after consent. So 39 patients ended up failing the SF-36 screening test. So they had an SF-36 which was 80 or greater, and so they came out of the study. So then that left us with our 200 patients who were eventually randomized into the two arms. So we've got the surgery arm on this side. 99 patients were randomized for surgery. Two patients decided they didn't want an operation, so withdrew prior to surgery. 97 patients have had their operation. Almost all of them have finished their 6-month follow-up, and we've got now about 75 or so who've completed a 12-month follow-up. Follow-up, as I say, will be completed by December this year. So that's the surgery arm. In the no surgery arm, we had 101 patients randomized to this arm. One patient immediately pulled out and went on to have their surgery paid for privately. And we were really worried about keeping patients in the study. And thankfully, this is the only time this happened. So the rest of the no surgery patients didn't have their operation, and 91 of them have been followed up to their 12-month time point. So just another 9 to go. And again, by December, everyone would have been followed up. And so we'll have a really high um, um, number of patients who stayed in the trial, and so the fidelity of the trial remains really intact, which is very exciting. So, the primary analysis plan, again, this has been agreed, sign off by the funder, the trial steering committee, and obviously the co-investigators put this together. The primary analysis will be intention to treat, as you'd expect in this sort of trial. And the primary outcome, as I've already said, is your change in SF36 PF score from baseline to 1 year, and we're measuring the difference between the two groups. Because we want to try and answer two questions, we have got what we call a gatekeeper procedure. So we will ask one question first, which is your SF36 different? And if the answer is no, that's the only question we'll ask. But if the answer is yes, then we're going to ask a second question, which is your predicted peak VO2 on CPET different between baseline and 1 year? So the gatekeeper procedure allows us to ask two questions, and that's really critical because we'll not only answer the sort of question about symptoms for patients, but we'll be able to answer. Sorry, let me just get rid of this. We'll also, oops, apologies. We'll also be able to answer or provide some insights into the mechanism that's driving that difference in primary outcome. So essentially, this is what the trial will tell us about clinical effectiveness. We'll either have a red light, which will be when we ask the first question, there's no improvement in physical function, in which case we don't ask the second question at all. So that's fine. Or we'll have a yellow light, if you like, where the first question, so physical function improves, but there's no improvement in cardiopulmonary function. And then we'll have to think about what that means. Or we'll have what I call a double green, which is that both physical function and cardiopulmonary function improves. And then we have a really clear answer for patients. So that's what we will expect. And that's the sort of, if you like, format in which we'll be reporting the findings of the trial. As I said, we've done CT scans in patients who've had surgery, so this is really key. Everyone had a CT scan within 6 months of their initial surgery, so CT scan post-op, CT scan pre-op, and what we found, much to our delight, is that the quality of the surgery is really, really good. So over 90% of patients at the end of the surgery have normal or mild pectus based on the Haller's index. A small number of patients, around 8%, still have moderate or severe pectus. And for these patients, actually, when you look at their pre-op Haller, they're really, really high. So these are patients where the Haller's gone from 20 to 4 or 25 to 6, etc. But because 90% of the patients have gone back to normal or mild Haller index, we can say that the operation has been really effective. Again, when we publish the data, we'll be able to show this quite clearly so that readers can make up their minds about the quality of the surgery. But really delighted with this because this was a real design conundrum for us at the beginning of the trial. The other thing, and this is really a slide for us trialists, really, is how good has the quality of the data been, and how well have we done in terms of keeping getting the data in and keeping patients in the trial. And the answer is we've done really, really well. So the amount of missing data is tiny in this trial. We've got all our baseline data. For the no surgery group, if you look at 12 months, we've got very small number of data missing. So if you remember, we had a 15% attrition built into the trial design because we thought we would miss 15% of our primary data. The data we're missing is tiny. It's 2%, 4% for our key outcomes. in the no surgery arm, 2%, 2% for our key outcomes in the surgery arm. So I guess the message I'm trying to get across is that, we set out to design, we set out with a trial design, which we've basically we've kept the patients in the trial. The operations have been really effective. We've got the data, and so we're going to be able to answer the question with real confidence. Just to say a couple of other things that are happening, we have a sub-study which is looking at perioperative TOE. So a small number of patients are having a TOE in theatre before their surgery and then after their surgery to look at right ventricular dimensions and volumes, because I think that will be interesting. And as I alluded to, we're doing a discrete choice experiment to really understand why patients choose one operation over the other. And this is just to kind of add to the picture and the story of pectus excavatum. Data acquisition and validation will be complete by December. We'll lock the data at that point, early January, and we hope to have an answer by spring. And so by May, April, May, June next year, we hope to be publishing this data. So really exciting. I think this is a really important study for patients. It's going to, for the first time, provide some really clear evidence of the risk and benefits in an RCT setting and help them decide what they want to do when they have severe pectus, which is causing symptoms. It's going to have significant impact internationally in terms of funding and commissioning. And we know that in the UK, that's what's going to drive commissioning guidance going forward. So I think a really important study, and I hope you're all excited to get the answer. Just a few slides, because I think I've got 2 or 3 minutes or so. Restores actually, when you have patients with a rare disease, it's really important that you kind of, if you like, capitalize your research opportunity when you get one. And so when we got funding to do this trial, we thought it was really important to do a cohort study to look at long-term outcomes as well, and particularly in patients who have a NUSS procedure, because for NUSS procedures, the bar is left in for at least 3 years. And so we essentially are running alongside the RCT a cohort study of 300 patients. And that's going to be the 200 patients who are in the RCT. They're all going to have surgery eventually. And then 100 patients from a national MDT, which is up and running in the UK, which is essentially looking at patients who have severe life-threatening pectus excavatum symptoms. And so those 300 patients are being followed up for 3 years and until bar removal. And we'll hopefully be able to present some long-term data on the outcomes of pectus in that cohort. That study has finished recruiting as well. It only finished recruiting in August, so just in fact a few weeks ago. Just a trial fuller diagram for that study. We assessed 115 patients from the MDT, of which 97 were included in the cohort study, and 48 have already had their surgery. And the idea, with that study is that we will provide within group differences. So it will be 300 patients. We have all their baseline scores, and then we're going to measure all those scores again at 3 years. And so for those patients, it will be within group differences. So in changes from baseline, it's a much bigger cohort. There's a broader spectrum of patients within that study. And again, that will just add to the total story of the impact of pectus excavatum surgery in the UK. So thank you very much. Eric, I hope that's useful and clear, and I'm happy to take any questions.
Amazing. Thank you very much for a great presentation. And also, many congratulations on designing one of the best recruiting randomized trials in the history of surgical trials in the UK, and I'm sure elsewhere in the world. Can I just ask for a point of clarity? The patients randomized to no surgery, is there a imputation in the design that they will have late surgery or no surgery at all?
No, so the primary outcome is measured at 12 months, where they would have no surgery. So we expect no patient in the no surgery arm to have an operation. The one patient who had surgery, as I say, although it's an ITT trial, so they'll be included. I don't think, if I remember correctly, they didn't give us permission to get their primary outcome. So I suspect we'll lose that data anyway. But essentially, everyone in a no surgery arm will not have had surgery. We'll measure the difference at 1 year, and that's the end of the RCT. But those patients were then allowed to go into the cohort study. So they'll have surgery later on because they'll be part of the cohort study that I've described. But for the RCT, it is strictly surgery versus no surgery outcome at 1 year.
Yeah, congratulations, because I think the carrot or the real star for this recruitment is the promise that everyone is going to have surgery, but you don't have the surgery within 1 year. And so you're
Exactly.
going to have surgery off trial. And
Exactly.
because there's no other way to get access to this, the recruitment has been massive because everybody actually wants the operation. Um, I've,
Absolutely.
I've got a few questions. Maybe I'll start. The design is obviously phenomenal, and there's two primary outcomes, and you've shown a possible three-layered scenario with the first and the third, which is both negative, both positive. That's relatively easy.
Yeah.
I'm more interested in the middle scenario because if you ask me to hazard a guess, I'm going to think that that's going to be the most likely outcome for the Restore trial.
Yeah.
Um, the middle outcome, which is improve physical function,
Yeah.
but no improvement to CPAT,
Yeah.
wouldn't that suggest, if that is the primary outcome, that people are just having a subjective feeling of, I do better?
I mean, I think that's right, and I thought that was so important to. That's why I thought it was so important to. Although TPET was really challenging and difficult, I thought it was really important to have that as an outcome and to test that with a hypothesis that was possible, because I think that was always going to be the criticism of the primary outcome in this study on its own. As I say, we chose that primary outcome because the NIHR rightly insists that we should measure things that are important to patients, and when we this is a commissioned call, and the commissioned call was very clear about the kind of primary outcomes that were appropriate. And actually, to be fair, was supported by patients. But I was always aware that clinicians will always want to see some objective improvement, or at least a mechanism that underpins that. So I agree. I mean, I think that it's there, and when we report, clinicians and patients can make that decision. So they can say, well, patients say they feel better, but the objective test doesn't show any difference. So I'll make this decision about commissioning or about my own care. So I just thought it's important to show it like that. I think you may be right that that's that's what the trial will show. It might not. We don't know, and that's the excitement of doing these trials, isn't it? We'll find out. But I think the key thing for me is that the higher quality information is out there, and people can make a decision about what they want to do.
Can I ask for the VO2 max studies, right? What's the minimum clinical difference that you're specifying for there to be a difference?
Um, I don't want to lie to you. I can't remember.
Okay.
But it's
So
it's go on.
so that would be a difficult number to derive, right? Because VO2 itself is so subjective as to what constitutes, you know, important or not. That's going to be quite, I think, discussed. And the reason why I'm asking all this is because this is a major landmark trial, right? It's the first ever kind of trial in this disease subset. And from personal experience, I can tell you 99.9% of surgeons around the world would not have designed a randomized controlled trial. And my own personal view is if the trial, if a surgical trial is positive in favor of surgery, no one says anything. They'll say, I told you so.
Yeah,
That's the standard response.
yeah,
If, however, in the unfortunate event that a surgical trial proves negative to what people are doing, I think you can expect a barrage of international criticism. And the
yes,
problem with the criticism, it's really low-level criticism. And the principal two areas where people criticize are that it's randomized trial don't reflect real world my patients.
yeah,
And the second unreasonable stance, which I can see people picking already, is that in my practice, I get 100% correction.
yes,
And because you haven't achieved that, your
yeah,
trial is worthless or hopeless.
yeah.
And just to prepare you, for this
I
approach.
yes, I'm completely prepared, and I completely agree about the second one, because I was really worried about that, and that's why we did those CT scans, and that's why the data will be out there, and you're absolutely right. Everyone thinks that all their operations work perfectly all the time, and because they see the patient very early in the process, they discharge them, and they think that they just sort of sail off into the sunset, and it's amazing. But I'm prepared for those criticisms. They will come. I think I agree with you that the answer is they are low-level criticisms. I think actually the effectiveness of the operation is pretty good, and when people see those few patients, when we provide the data of those few patients who haven't had their HALA corrected to perfect, it would be very reasonable. And I think that surgeons will see that those are outcomes that are very reasonable outcomes. So I completely agree with those criticisms. I think if this study is negative, in many ways, the impact, as you say, will be huge if it's a negative study. I expect journals and everyone to be much more interested in my message if it's negative than if it's positive. And one of the amazing things about doing a trial in an area where I don't practice, I am completely kind of objective, and I'm really excited to see the outcome. I've tried to do a really fair study so that we get the best possible answer. So I'm genuinely sort of not conflicted, and
Equipoise.
yeah, I have
Yeah.
true equipoise on this occasion, indeed.
I think that's entirely the same for me for Mars too, but that never got the actual intended outcome that we wanted. I got a question from Dr. Buckets who's asking, on everyone's mind, I think, in the audience, is that, this operation is to correct the torture of having the physical abnormality so that they feel much better about themselves after
Yeah.
surgery. And people think that or consider that to be the principal reason for or one of the very important reasons to do pectus surgery. What's your view on that?
Sorry, just ask that again in terms of.
I.e., mental wellness
Okay, so
as the
well,
principal reason.
okay, so psychological impact of having pectus surgery in effect. Yeah, I mean, I think we were the commission call was very clear that this trial was not to answer that question. Okay, so I think the evidence of cosmetic and psychological impact, I think is pretty strong actually. And there is quite a lot of data out there. We will be measuring depression and anxiety before and after. So we measure it before, we measure it 6 months, we measure it 12 months. And for those in the cohort study, we'll measure it out to 3 years. So we will get some information on that. But that's not the primary aim of the study. I mean, it's a secondary outcome, as I've already alluded to. What's the interplay between that and the primary outcome of physical function scoring? I mean, I guess that's what we've been discussing already, really. But I think the evidence of psychological benefit and cosmetic benefit is reasonable, and you can read about that. It's well published and well studied.
Yeah, I presume it's more in the UK, especially, it's more about cost effectiveness, right? So then, for a study which has cosmesis or mental wellness as a principal outcome, may not be funded as compared to an actual physical or
Correct.
quality of life or extending your life outcome. And because we live in a national funded healthcare system, these questions are important to the UK as opposed to countries where patients can pay to receive X, Y, and Z treatments.
Absolutely, that's absolutely correct. I mean, we haven't really labored it too much, but the health economic component is a really important part of the study. And um, pectus excavation is major surgery. I haven't showed you the adverse event profile, but there are lots of adverse events as you expect from a major thoracic operation, and that those adverse events cost money. And when you follow them very, very carefully over a prolonged period of time, they add significant costs. So I think the cost-effective evaluation is going to be really critical in the UK in terms of commissioning going forward. Yeah.
Excellent. Thank you so much. Well, once again, thanks to our sponsors. We always have too many questions and not enough time to answers. To mention Medtronic, Medela, and AstraZeneca. Next week, we're going to talk about ex vivo lung perfusion, and we're going to have Professor Marcello Seipel joining us from Toronto, which leads me once again, to thank you for your fantastic presentation today, and congratulations with you and Joel Dunning on the leadership of this groundbreaking trial. And we wish you all the success and support in the presentation of the results next year.
Brilliant. Thanks, Eric, and thank you everyone for tuning in.
Thank you. Bye-bye.